All right, next up is transanal endoscopic surgery with peritoneal entry, a word of caution, presented by Dr. Molina from the group at MGH. I think we'd also say it's interesting to comment about young patients with cancer. I think in the US, that younger patients, for whatever reason, prognosis seems to be worse.
Thank you for the introduction. We have no disclosures. Transanal endoscopic microsurgery was pioneered in 1983. Full-thickness excision of rectal lesions with TEM has been shown to be safe. And when it is used for low-risk and carefully selected T1 rectal cancers, it has equivalent long-term oncologic outcomes to radical surgery. The TM technique includes an operating proctoscope that is typically 4 centimeters in diameter and varies in length. And it has a faceplate with 4 ports through which a laparoscopic camera and modified laparoscopic instruments are inserted. In 2009, transanal minimally invasive surgery, also known as TAMIS, was developed. It offered a cheaper alternative to TEM. TAMIS is defined as the use of a disposable transanal multi-channel single port combined with the use of ordinary laparoscopic instruments and camera. TAMIS has also been shown to be safe, but there are insufficient long-term follow-up data to assess oncologic outcomes. There are multiple TAMIS platforms available for use. Early TM reports treated peritoneal entry aggressively by converting to an open approach and either performing a low anterior resection or a protective loop sigmoidostomy. Contemporary studies, however, have demonstrated that peritoneal entry with TM can be managed transanally and without an abdominal exploration, and that it is neither associated with worse outcomes nor associated with adverse oncologic effects when treating cancers. Conversely, peritoneal entry with TAMIS has not been as widely reported as it has been with TEM. This study was a retrospective review of all TEM and TAMIS cases performed at MGH between January 2008 and December 2014. The primary outcome of interest was intraoperative peritoneal entry, defined as the abrupt loss of pneumorectum during full-thickness rectal wall dissection with concomitant development of pneumoperitoneum with or without visualization of the peritoneal contents. The mean age for the entire cohort of 78 patients was about 61 years. The majority were women. The most common surgical indication was endoscopically unresectable adenomas. There were 21 cases performed for T1 rectal cancer and 5 cases for T2, T3 rectal cancer. The rigid platforms are the most commonly used. Only 7.7% of all cases used a TAMIS platform, which amounted to 6 cases. The mean distance from the anal verge was 9.6 centimeters, with a third of lesions located in the upper rectum rectal sigmoid region. The majority of lesions were located in the posterior wall of the rectum. There were a total of 22 cases of peritoneal entry. Platform was significantly associated with peritoneal entry, with 2/3 of all TAMIS cases having peritoneal entry, compared to only 1/4 of TM cases. Cases with peritoneal entry also had lesions located significantly farther away from the anal verge. Near circumferential lesions had the highest incidence of peritoneal entry. Cases with peritoneal entry also had significantly longer operative time and larger mean specimen size compared to cases without. The 4 TAMIS cases with peritoneal entry had critical loss of pneumorectum that precluded adequate closure of the rectal defect. All of these cases were salvaged by converting to a rigid TEM platform, which effectively stented the rectum open and permitted closure of the defect. Intraoperative complications included 2 TM rigid platform cases that required conversion to a laparoscopic LAR and a Hartmann's respectively, due to critical loss of pneumorectum and an inability to safely close a rectal defect after peritoneal entry. The most common postoperative complication was urinary retention. In this high-risk series, with 1/3 of lesions located in the upper rectum or rectosigmoid, safe management of peritoneal entry was feasible in 91% of cases. TAMIS cases that had critical loss of pneumorectum were salvaged by exchanging to a rigid platform. Therefore, we advise caution when considering short TAMIS platforms in cases with a higher risk of peritoneal entry, especially in centers where backup rigid platforms are not available. In these particular cases, a longer TAMIS platform should be considered. Our study has certain limitations. First, the retrospective nature of our study design could not control for biases in surgeon choice of platform or patient selection. Second, our findings are from a single institution and therefore could not be generalizable. Third, this is a small series of TAMIS and TEM procedures, which prevents us from making definitive conclusions and saying that there are significant complications associated with either platform. Thanks.
Thanks very much. So an interesting experience and a number of questions that have arisen. And the first question coming from the audience, and I'm trying to do my best I can with all this equipment here, is what determined the use of TAMIS versus TEMS in the cases? And was it, basically, was it one surgeon trying TAMIS to do it, or what determined TAMIS versus TEMS?
So that was a surgeon preference, and I think that's a great question. TAMIS became available a couple of years after the TEMS platforms, and it was a product of trying to have more experience with TAMIS, but that was purely surgeon preference and obviously a bias.
And so was there more than one surgeon that did the TAMISes? Or was it one surgeon?
No, there were more than one surgeon.
Okay.
John Marks from Lacanal Hospital in Philadelphia.
Hi.
Hi. Congratulations on a very nice series and presentation. I'm wondering if you could, perhaps I missed it, if you could explain to the audience how it is you manage the closure into the peritoneal cavity. Was this done then in 2 layers or a single layer? And the corollary to that is, aside from the lower anterior and the Hartman, were there any times that you felt compelled to go in abdominally or divert? And then the last question is, did you look at where in the learning curve you ended up in the peritoneal cavity, the percentages, and if this increased as your experience went on and you were taking on more difficult lesions or not? Thank you.
So the peritoneal entries were closed transanally with a single layer closure. We only had to do an abdominal exploration with laparoscopy twice. So never was there a case where we explored it laparoscopically just to make sure to do a test. It was just those 2 cases. And with peritoneal entry, these were 3 surgeons, and they felt that they actually did get better as time progressed. And what they realized were a couple of things. Placing patients in the prone position, if they anticipated that they were going to have a peritoneal entry, helped with getting, if they did get peritoneal entry, it helped with actually closing it. This was all just anecdotal, and they felt that having patients in the prone position, if you did have peritoneal entry, you had a faster equilibrium of exchange of CO2 from the transanal and then the peritoneal because of the tamponade effect. And that helped, and that was actually instituted, after some experience with the operations. And then I forgot your third question.
You covered it. So I just want to take a second before we ask another question. We've got a minute or 2. How many of you people do TEMS or TAMIS in your practice? Over here, so a number of us. And so I think the interesting part is questioning regarding intraperitoneal entry and closure. Do you have a protocol then afterwards? If you do an intraperitoneal approach and close it, do they get water-soluble studies day 1 or day 2, or what's the algorithm?
So for all patients in this study, and anybody that gets a TEMS or TAMIS gets admitted overnight and gets observed. There's no protocol for doing any type of test afterwards. We've experienced that patients do quite well. A lot of the big studies have shown that peritoneal entry is not associated with worst outcomes. So there's no protocol for testing day 1, day 2, et cetera.
So just to clarify, in a circumferential lesion that you remove, that's an intraperitoneal entry, they would just stay till the next day?
So it's closed transanally. So the rectal defect is closed, and they're admitted overnight. Okay. If they're doing fine and doing well and have no other reason for us to be concerned from a comorbidity standpoint, they get discharged.
Molly, you do a fair bit of TAMIS. I guess the question is do the number of cases you do of TAMIS allow you then to learn or overcome this? How about in your practice?
In my practice, I've had 2 peritoneal entries with the TAMIS platform, and both I was able to salvage with TAMIS. It may have been positioning, it may have been luck, but I think after experience is gained, after 20, 30 TAMISes, I think it gets easier. So
that's the question so what was the largest experience of any one surgeon doing TAMIS? Was it 2 cases, 3 cases?
So the largest experience was 3 cases.
3 cases. And so I guess the question would be is, do we know, is that an adequate enough learning curve with the technology and technique?
Right.
So the point here is that inexperience with TAMIS and intraperitoneal entry is challenging.
Well,
is that it?
It is challenging, but I think also just the point that the TAMIS platform is shorter. And I think it's not a matter of TAMIS or TEMS necessarily, but it's just the length of your platform, and if you are being aggressive and going after lesions that are farther away from the anal verge. And I think that's probably the takeaway message that I would like to share.
All right. Well, thanks very much.
Thank you.
Appreciate it.